Welcome to another Six Patterns video. My name is Max.
I'm Kevin.
And this is another one in our series of the top 25 pearls of pulmonary pathology. And we're in the topic about the importance of clinical and radiologic correlation and how that can impact your pathologic interpretation and diagnosis. So we've got a case for you.
Yeah, beautiful. So this is a young woman. This is a 30-year-old woman. And she, or 31-year-old woman, presents with shortness of breath. She's got a cough, and she's also got malaise. They don't say how long it's been going on, but they say she's definitely got interstitial lung disease on imaging.
Okay.
Ground glass infiltrates, presumably. We don't know how much traction bronchiectasis for fibrosis.
We actually don't know. We just know that
any
it's
of this stuff.
interstitial infiltrates, right?
Right. So a VATS biopsy is done, and here's the VATS biopsy.
Boy, if this, we're going to have a whole session on the blue biopsy, right?
Yeah.
And maybe we should have put this one in the blue biopsy session because this is a blue biopsy, like big time.
Yeah.
So we're thinking inflammatory cells.
Yeah.
So maybe we should go look at higher power.
Yeah. So, and it looks to me like it's, I don't want to say it's completely diffuse. It looks a little denser some places than others, but it looks like it's abnormal even at the smallest places.
Even out here, it's distinctly abnormal.
Yeah. And I mean, finding one tiny 4 millimeter area of just one alveolar wall that isn't involved isn't enough. I mean, if you had a whole zone.
You have a region.
Right. And these look like lymphocytes to me, and probably are plasma cells. And look at that. Looks like a giant cell right in the middle.
That is a giant cell right there. And we've got a lymphoplasmacytic infiltrate.
Wow.
So,
Hypersensitivity.
I mean, do you need to look any further? We've got an alveolitis. We've got a vague granuloma giant cell.
She probably owns a bird.
Perhaps owns a bird. There's another vague granuloma there.
Yeah.
Now, if you watched our previous video, you might be saying, well, this looks a lot like what you just described in GLILD.
Interesting. Maybe this is GLILD. But we have no history.
But it's got to be on the differential diagnosis at this point, right?
Yeah, absolutely.
Could be HP.
You have
could
to
be
include
GLILD.
It's a little too cellular for HP. You know, we talk about it being an alveolitis, but you know, hypersensitivity in its cellular phase, in the subacute phase, tends to be a slightly pinker disease, meaning there are plasma cells, but there aren't this many lymphocytes in aggregation. And that's a lot of lymphocytic pleuritis.
Look at that pleuritis. Now, you don't
with
see
a granuloma in it.
With a granuloma in it.
Okay. Yeah, wow.
So some people would call this LIP.
Well, and descriptively, it's a lymphoid interstitial pneumonia. I mean, you could say generically,
right.
That's correct. But LIP is meant to mean something pretty specific.
Exactly.
And there's so many definitions online of it. I wouldn't even recommend that you Google it because it depends on what year you look at. If you look in 1950, right?
All of the descriptions of LIP in the 1950s, 1960s
were low-grade lymphomas.
They were low-grade lymphomas, exactly. And so because of that, the term LIP was kicked out of the classification of idiopathic interstitial pneumonias in
because
the 1990s.
It was presumed they were all low-grade lymphomas.
Presumed they were all lymphomas.
But some weren't.
Some weren't or couldn't be documented to be.
Correct.
And so it got put back into the classification as a rare idiopathic interstitial pneumonia. Now, my challenge with this diagnosis of LIP is that as someone who wasn't a part of that history in the 1990s.
Yeah. Thank God you didn't say 1950s.
Wasn't a part of the 1990s history.
Yeah.
When I came across learning pulmonary pathology, I started to scratch my head when I read the descriptions of LIP, pathologic LIP, because it was described as a dense cellular interstitial infiltrate.
Lymphocytes and plasma cells.
Lymphocytes and plasma cells. And then as I went on further in the chapter of chronic diffuse interstitial lung disease, I read the description of cellular NSIP, dense lymphoplasmacytic infiltrate expanding the interstitium. So I started to scratch my head and I said,
I think these may be the same disease.
What's the difference between LIP and robust cellular NSIP? And the reality is there's probably not a whole lot of difference.
Right. And NSIP has become such a dominant term now. I think LIP is just getting pushed off the shelf. It's too confusing a term. It means different things to different people. So this case did get signed out. How did it get signed out? Pathologists called this on the outside,
It probably should have been called,
called it hypersensitivity pneumonitis
well, that's reasonable. They could have also called it LIP
or cellular NSIP,
or cellular NSIP.
with a differential diagnosis to include all the things that could cause any of those three conditions.
Exactly. So now we're going to get to the real important part, and that's how we're talking about correlating with the clinical history and the imaging studies. Now, the imaging studies on this particular, remember it's a young female. The imaging studies are described as innumerable, bilateral, thin-walled cysts with a little bit of ground glass opacity in the background.
So they were thinking it might be LAM, but the interstitial changes in the background argued against it because LAM has normal lung in between the cysts. So the radiologist said, I think this is the radiologic condition we term LIP. Now the radiologists have an LIP.
A term that we didn't like in the first place.
We didn't like it in pathology, so they said, well, we'll take it. And they're using it for cystic disease in the lung.
Which looks nothing like pathologic LIP. Pathologic LIP is dense cellular interstitial infiltrates that should be concerning for lymphoma.
Yeah, so cystic disease is called radiologic LIP. So to make sense of it all, the framers of the ATS-ERS idiopathic interstitial pneumonia update said, well, LIP is many things. And LIP can have cysts on imaging.
And it happens.
It does.
In fact, there's one disease that's the perfect LIP disease that unifies radiologic
and
pathologic LIP, and that's Sjogren's syndrome. Because those patients get cellular interstitial infiltrates, and they get cystic lung disease on radiology.
They can have cysts.
They can have
and they can develop the rare occurrence of lymphoma.
Exactly.
So they're at risk for lymphoma. They can have cysts on lung CT, and they have cellular interstitial infiltrates that you might squeeze into the category of LIP.
So how do you handle LIP? Me personally, I've never made a diagnosis of LIP.
Well, you swore you never would. So
Exactly.
You've been true to your swear.
Exactly. So if you wanted to put a general pattern on this, I'd say it fits best with a robust cellular NSIP pattern.
Accompanied by small, non-necrotizing,
granulomas. And to me,
pleuritis.
To me, in this case, the outside diagnosis was hypersensitivity pneumonitis. You typically don't see this degree of pleuritis or really any chronic pleuritis in the setting of hypersensitivity pneumonitis. And so I think it's probably not hypersensitivity pneumonitis. So we've got a young lady with a dense cellular NSIP with bilateral cystic lung disease on imaging studies.
And you've diagnosed it as HP. And the clinician says,
this doesn't make any sense.
Wait a minute.
This doesn't make any sense.
This is the clinical radiologic pathology correlation bit, because the clinicians are listening. And when you diagnose LIP, they expect to see certain things. And this clinician said, no, this doesn't look like hypersensitivity pneumonitis.
Right. There's no fuzzy nodules. There's no vague fuzzy nodules. The patient has no exposure history. It's not mid-upper lung zones. Like, it's just not making any sense.
So it's sent out.
So really the pearl for this case is, or the pearl for this session is A, LIP for the most part doesn't exist. You can practice in a very busy pulmonary pathology service
your whole career
and never use the term LIP
safely,
and you'd be doing just fine.
Right.
Okay, so you can pretend that LIP is off the table for a possibility. If you see something that you think you might want to call LIP, it's your job to make sure there's no lymphoma there.
Right.
Okay, so do your stains 320 kappa and lambda by in situ hybridization. If you ever hear a radiologist say, this looks like LIP, you have to understand that they're not talking about dense cellular interstitial infiltrates under the biopsy.
They're talking about cysts.
Talking about bilateral cystic lung disease.
Now, this patient had cysts. Why don't we see the cysts? You don't get them.
They don't sample the cysts, and if they do, they collapse.
You don't see them.
And you don't see them. So it's very common to have a biopsy for cysts with no cysts.
And you might be thinking, well, what are the cysts of LIP? And the cysts, in cases where we've seen biopsies that have collapses, they're always next to a small airway. So I think they're probably occluded small airways that get hyperinflated, and they get a ball of trapped air. When they do the VATS procedure, the lung collapses, the cysts collapse, you don't see them.
Exactly. So when a radiologist says LIP, it's cystic lung disease, and every pulmonologist and every radiologist will be thinking about one category of diseases when you have radiologic LIP, and that is
Sjogren.
Or as a general category, connective tissue disease.
Yeah.
Right? So when you have a biopsy like this, that's a robust cellular interstitial infiltrate, call it a robust cellular interstitial, a robust cellular NSIP, and raise the possibility of a connective tissue disease.
Evolving or occult connective tissue disease, which I think is what happened in this patient.
That's exactly right in this patient. I'm not exactly sure what connective tissue disease was identified, but we do have this category now. If the patient was not identified to have a definitive connective tissue disease, there's something called IPAF.
Right.
Interstitial pneumonia with autoimmune features. This has been referred to as a number of different things throughout the literature, but it's basically a patient who presents with interstitial lung disease with signs and symptoms that are suggestive of a connective tissue disease,
but not diagnostic.
but they don't meet criteria for one of our well-defined CT connective tissue diseases. So if you have RA, you can't have IPAF.
So IPAF is only used if the patient does not qualify as having an autoimmune disease clinically. But all the features suggest it has a strong possibility. Then you can put the patient in the IPAF category as a research tool to gather these people together to try to figure out what exactly is going on with them.
Exactly. So remember, for practical purposes, LIP does not exist. Pathologic LIP and radiologic LIP are two very separate things.
And if you're thinking you'd like to diagnose LIP, get a CD20 stain.
Get a CD20 stain, make sure it's not lymphoma. And then call it a robust cellular NSIP.
Right.
Well,
we nailed it.
I think we took care of that one. Hope you enjoyed it. Don't forget to like and comment below and let us know what you think.
See you next time.
Thank you.